Doctor, welcome to Mexico. Thank you very much.
Thank you. Gracias. So I will begin. My name is Anish Ray. I grew up in India, where I went to medical school, and then I moved to the United States for further studies. And I've been living in Fort Worth for the last 5 to 6 years, practicing as a pediatric hematologist, oncologist. Thank you so much. I want to especially thank the organizing committee for inviting us to this great conference. This morning there was an extensive discussion on Hodgkin lymphoma, and I learned quite a bit. And we are changing gears here, moving from Hodgkin lymphoma to hemophagocytic lymphohistiocytosis, also abbreviated as HLH. This is quite a rare disorder, and I wanted to highlight the importance of being aware of this entity in our pediatric patients who receive chemotherapy and are in the hospital with fever, neutropenia, anemia, and thrombocytopenia for prolonged periods of time. So this is a brief outline of the presentation. We will provide an introduction to HLH, as well as present a few clinical cases, and then provide results and summarization, and then take some questions. So introduction to histiocytic disorders. I know there has been an emphasis in this conference on histiocytic disorders. So today we're talking a little bit about HLH, and tomorrow we will discuss another conference on LCH disorders. So divided into 3 classes, as you can see, class 1 consists of dendritic cell disorders, namely Langerhans cell histiocytosis and juvenile xanthogranuloma. Class 2 consists of macrophage-related disorders, namely HLH, as well as Dorfman. These are all very rare conditions. And then class 3 is the malignant histiocytic disorders, certain subtypes of AML, M4, M5, as well as chronic myelomonocytic leukemia and histiocytic sarcomas. So a brief overview of HLH. It has been described a long time ago, back in the 1930s, and first it was described to take place among patients within the same family. So it was first described as familial or primary HLH, and then we realized that the mode of transmission is autosomal recessive. We have now come to understand that there is a genetic basis for primary HLH involving genetic mutations that affect normal functioning of T lymphocytes and natural killer cells. Typically, primary HLH or the familial HLH is seen in young children, sometimes in infancy, but not always will we find a positive family history. So epidemiology-wise, anywhere between 1 to 225 per 300,000 live births. So as you can see, it's quite a rare disease, and perhaps underdiagnosed because we are often not thinking of this entity when we are taking care of patients as clinicians. The overall problem in HLH is that of an overactive immune system, but it is ineffective in protecting the patient from infectious complications. There are some HLH-associated conditions. Sometimes it is seen as a familial disease. In association with consanguinity, also can be secondary to infectious agents such as EBV, CMV, and parvovirus. So right before I came here, I was taking care of this little girl with lymphoblastic leukemia, who has been admitted to the hospital with prolonged fever of unclear etiology, receiving maintenance chemotherapy when we don't expect them to be so immunocompromised. And then we checked labs and found that ferritin was high, and other supporting factors for HLH were also high, but eventually she grew CMV from her blood and was able to fight it off on her own, and the HLH also subsided. You can see HLH, secondary HLH, in the setting of T and B cell leukemias, as well as some lymphomas, as well as some rheumatologic conditions such as Kawasaki disease, lupus, and juvenile rheumatoid arthritis. I have taken care of several patients who started seeing the rheumatology doctor because they had juvenile rheumatoid arthritis, and then eventually they developed fever, and labs were abnormal, showing cytopenias, and got referred to us, wondering if this is a case of HLH. In those cases, we have tried to emphasize on treating the underlying disorder, namely rheumatology disorders and arthritis, in order to pre-treat the HLH. So pathogenesis-wise, there are 2 problems in HLH. One is an uncontrolled activation of T lymphocytes and macrophages, and on the other side, you have an inhibition to downregulate the overactivated T lymphocytes. So as a result, there is an abundance of cytokines in peripheral blood, namely excess of IL-2, IL-6, IL-1, TNF-alpha, interferon gamma. With all of these, as you can see, we can see some of the clinical signs and symptoms for our patients, namely prolonged fever that won't subside, as well as signs of bone marrow suppression, leading to cytopenias, inhibition of lipoprotein lipase that leads to hypertriglyceridemia. If you check in the bone marrow, sometimes you can see hemophagocytosis. But I want to point out here that hemophagocytosis in the bone marrow is only one of several criteria that need to be fulfilled to make a diagnosis. In the absence of hemophagocytosis, it is possible to diagnose a patient with HLH. So that's important to keep in mind as you are taking care of your patient. With combination of inactivation of T cells and macrophages, the overall picture is that of poor NK cell activity as well as poor cytotoxic T lymphocyte. And then there is the perforin and granzyme system that is ineffective in these patients. These are sophisticated lab studies that take sometimes weeks to come back. So if you're suspecting if your patient has HLH, I suggest that we not wait for all the lab studies to come back and instead start treating, because these patients can get very sick very quickly. So overall, the perforin and granzyme system, as you can see here, the perforin is a protein that T lymphocytes or NK cells will use to make a hole on the surface of the target cell. Once that hole has been made successfully, the granzyme enzyme system then leads to killing of the target cell. This entire process is hampered in patients with HLH. So presentation for patients, moving on to the clinical aspect. Patients can present with fever, prolonged fever for several days, as well as rash of unclear etiology. They can be irritable. They can have enlargement of the lymph nodes, as well as enlargement of the liver and spleen. So as a concerned clinician, when you start checking labs, you can find pancytopenia. These patients can have signs of coagulopathy. Without frank bleeding, they can have abnormal liver function test. And then if you look, there can be elevation of ferritin and triglycerides. If you're concerned about HLH, you then further perform a bone marrow aspirate that may show macrophages engulfing any blood cells, also known as hemophagocytosis. So some of these patients can present with neurological problems also, such as seizures, cranial nerve deficit. There can be problems with breathing. There can be signs of subdural hematoma or blurry vision. With all of these problems, if you check CSF, there's an abundance of white cells. All of these are usually non-specific findings, and you're wondering what your patient have. If you don't specifically look for a blood ferritin or a soluble IL-2 level, you will not be diagnosing patients with HLH. So we took up this study where we wanted to understand the presenting pattern for patients with signs and symptoms that can be confusing in the setting of cytotoxic chemotherapy, especially those with malignancy. We wanted to understand their clinical presentation, and our goal overall was to bring awareness to secondary HLH. So for methods, we looked at medical records for our patients between June 2006 to June of 2016, so overall a 10-year period. And we looked at the data for patients who were diagnosed with secondary HLH during this time period. So here are some of the clinical cases. I'm going to present 3 clinical cases, and they may seem very common based on your practice. I think you will identify several of your patients in this presentation. So first patient is that of a 9-year-old male. He presented with AML, received standard induction chemotherapy with cytarabine, daunorubicin, and etoposide. 1 month into treatment, he is persistently febrile. Day 22, day 23 starts becoming febrile. We obtained blood cultures without any bacteria being identified. And then he had a bone marrow aspirate done because we wanted to see if this child is in remission or if this fever is a sign of his leukemia returning. And we found an abundance of hemophagocytosis as reported by the pathologist. So with that, we started looking further. We checked labs and found that the patient also had high ferritin level. We checked further for soluble IL-2 receptor levels that were also high, and other supporting labs that eventually led to the diagnosis of secondary HLH. His blood culture a few days later started to grow aspergillus, which was probably driving this HLH in this patient. He was promptly started on treatment with etoposide and dexamethasone, and unfortunately he passed away from HLH not being under control, although he remained in remission from his AML. The second patient presented with relapsed AML, again received cytotoxic chemotherapy, and was at home with very low numbers. His immune system was profoundly compromised. He presented to the emergency room with fever, chills, nausea, diarrhea, generally not feeling well. We obtained labs, blood culture quickly grew enterococcus, and then in the hospital, despite being on antibiotics for several days, he was persistently febrile. At that time, we started wondering about HLH, and then his ferritin was also high, and then other supporting labs were obtained that diagnosed him with HLH. He went into remission with dexamethasone and etoposide, but eventually passed away from his AML. The third patient is that of somebody with relapsed acute lymphoblastic leukemia who presented with fever and splenomegaly following first cycle of chemo upon relapse. And then further labs were drawn. By this time, we were starting to become a little more aware of our patients who are getting chemotherapy and they present with profound fever and cytopenias. This patient actually had several relapses of her HLH. The first time she was treated with steroids and chemotherapy and went into remission, and then underwent bone marrow transplant and was in remission with regard to her leukemia, but then subsequently, 3 weeks later, she again presented with fever without a clear source and required treatment for HLH. 5 months later, when we expect these patients to have engrafted from their bone marrow transplant, she again presented with prolonged fever without clear etiology and required treatment. But fortunately, several years down the line, she remains in remission and continues to do well. So here is a summarization. We have all 3 patients who presented with fever, cytopenias, as well as non-specific lab abnormalities. A lot of times we get consulted to see our patients in the ICU who have been admitted for unclear reasons with fever, infectious disease doctors are following, rheumatology doctors are following, and then somebody checks a ferritin, and that turns out to be high, and they will call us. We come back and review labs. We notice that these patients have non-specific abnormalities, so they have abnormal liver function tests, profound cytopenias, and then we look for other sources and other factors that help us establish the diagnosis of HLH. Oftentimes, it is missed because we have not thought of HLH for a long time. It is a rare disorder. We're looking at common things, bacterial, viral infections, sometimes even fungal infections. So if we summarize here in this table, we've notice that not all of the symptoms that are associated with HLH are present in all the patients. As you can see on the top, there is fever in all 3 patients, and not all of them had splenomegaly. Several of them had peripheral cytopenias, but ferritin continues to stand out as a marker that is persistently elevated in these patients, anywhere between 4,000 to 15,000. And subsequently, we have checked soluble IL-2 levels, but these take a few days to come back, and your patient may quickly get worse while we're waiting for soluble IL-2 results to come back. So this is the diagnostic criteria we use to diagnose patients with HLH. Remember, patients must have 5 or more of the following: unexplained fever, 6 or more days, enlargement of the spleen, peripheral cytopenias involving 2 out of 3 cell lineages, so anemia, leukopenia, thrombocytopenia, hypertriglyceridemia, which is typically tested in the fasting setting, and then hemophagocytosis on bone marrow. Other things such as NK cell activity, these are sophisticated lab testing, like I said, take weeks to months to come back, so I don't think we should wait for these results to come back before we make a diagnosis. But ferritin is an easy lab test that can be done and can be reliably used to diagnose patients with primary or secondary HLH. If you look at the overall list of these symptoms, a lot of them are non-specific. We know patients under our care right now who have a fever, maybe a little enlargement of the spleen and the liver, some abnormal LFTs because they have received chemotherapy. If we are not specifically looking for HLH, we are not able to diagnose them. The other point I want to make is oftentimes this is an evolving disease. So just because a patient doesn't meet the criteria in the beginning, those patients in a matter of a week or 2 can then proceed to develop HLH. So how reliable is ferritin? As we know, ferritin is an acute phase reactant. If you have fever or you're sick from a variety of conditions, you can have elevation of ferritin. Also, our patients are chronically transfused with red cells. That can also lead to a baseline elevation of ferritin anyway. If you look at this list here, besides HLH, you will also have other conditions such as shock, those patients who have received bone marrow transplant, heart disease, liver disease, as well as various bacterial and viral illnesses can have elevation of their ferritin. But if you look on the very left, number one is ferritin, is HLH, and as you can see, it clearly stands out the most highest number for HLH patients. So we looked at this study. This is a paper that came out in Pediatric Blood and Cancer, looking at the value of ferritin for diagnosing patients with HLH. And if you can, as you can see, if you go into the 10,000 range for ferritin, it is both sensitive and specific in the 90% range for diagnosing patients with HLH. And so what's the treatment for HLH? It has two purposes in treating. One is to take care of the hyperactive immune system, and that is accomplished with a combination of dexamethasone and cyclosporine. On the other hand, we have activation and proliferation of lymphocytes and macrophages. So we use etoposide to cytoreduce. So the combination of etoposide and dexamethasone is the treatment for patients with HLH. And those patients who do not respond or show signs of relapse can be cured with bone marrow transplant. So this is a result from the HLH-94 study, where they looked at the success of bone marrow transplant in patients with HLH, 3-year overall survival of 63%. Of course, those who received match-related donors had higher survival of 64%. I want to point out that unlike our leukemia patients who need to be in MRD negative status for successful BMT, for those with HLH, it does not matter if the HLH is under control or not at the time of going into bone marrow transplant. And so here is again a combination of treatment plan, induction with dexamethasone and etoposide, and then we wean the dexamethasone after the first 2 weeks. We wean etoposide also going from twice weekly to once a week as the patient tolerates and there are signs of improvement. Sometimes patients will undergo a maintenance treatment phase with cyclosporine and dexamethasone and etoposide. If the patient's clinical condition improves, we can stop after 2 months. However, if there are signs of reactivation, you can either treat them again, going back to dexamethasone etoposide, or consider bone marrow transplant, but that is not an easy decision to make. So as oncologists, we love roadmaps. Here is a roadmap for patients. As you can see, dexamethasone on top. We begin at 10 milligram per meter squared twice a day, and then taper after the first week. Etoposide we give twice a week in the beginning, and then taper to once a week, finishing a total of 2 months. Some of these patients who have evidence of primary HLH, so that their NK cells or lymphocytes are found to be defective, these patients are not going to be cured with this. So you may be able to remission, but these patients are going to relapse in a matter of time, especially in the young infant setting. So those patients will be from bone marrow transplant, so we can use that time period to plan for bone marrow transplant if that is possible. Again, this is 60% survival for those patients who receive bone marrow transplant. Overall 5-year survival of 61%. Here is a summarization of our present. So as you can see, beginning with physical examination, and then with high suspicion for HLH, you check for specific labs, including ferritin, soluble IL-2. If possible, check for NK cell functions, and then also check for specific geneticities. And then once you've decided that this patient has HLH, I think the most important thing is to look for the underlying condition. So is it a malignancy that's triggering secondary HLH, or is it an infectious problem? Patients who have EBV-driven HLH will benefit from receiving rituximab on top of dexamethasone etoposide. And for signs of relapse, you can consider sending these patients to bone marrow transplant. Some reference, and I will take some questions.
Preguntas para el doctor Daniel. Preguntas. Perdón. A ver, vamos a bajar. La voy a hacer de. No, de EDK.
Buenas tardes. Pues quiero preguntarle si en sus protocolos incluyen el uso de gamma-globulina.
Yes, go ahead, please.
¿Ahí? Okay.
So, repeat your please.
Pues quiero preguntarles si en sus protocolos utilizan gamma-globulina o desde cuando ya no la utilizan.
We have not used, so are you on IVIG? So we have used IVIG as part of supportive care, but not routinely. We IgG levels, and if that's less than 500, we would consider giving IVIG every 3 weeks.
Okay.
Yeah.
Thank you.
¿Alguna otra pregunta para el doctor? No. ¿No? Sí, por ahí.
In secondary HLH, the underlying disease. Most of these patients, if they respond in that, they don't require to go to transplantation. The statistics that you show on this 60% transplant are patients who fail the primary.
Absolutely. You're correct. You're correct. Any other questions?
Buenas tardes, doctor.
Buenas tardes.
Muchas gracias por su confianza, muy educativa. Tengo duda y es encaminada hacia los criterios médicos. Veíamos en las diapositivas que son 5. ¿Qué pasa si los pacientes no cumplen todos los criterios y nosotros tenemos una fuerte sospecha clínica de que estamos frente a una linfohistiocitosis? ¿Empezamos o no? Perdón, son 8. Entonces,
that is a great question. That is a great many patients do not follow the textbook. They do not come with these criteria fulfilled. And it has been my experience that this is such a deadly disease that if you have a high clinical suspicion, patient's fever is going down, and you have cytopenias and the ferritin is rising, I recommend that we start treatment. We have faced with such dials in our practice, and we have sometimes started dexamethasone, did not want to give chemotherapy because it's a bigger commitment. And watch the patient closely for a week or 2. If there are signs of improvement, we would continue the steroid and taper. Signs of worsening, we would add chemotherapy to intensify treatment. Yeah. I brought some pictures of our program. So this is our team. Consisting of those who practice hematology or most oncology, as the bone marrow transplant doctors, the stoma specialists, posing with some of their patients. So this is one of our bone marrow transplant doctors. She's the medical director. She's not able to present. She sent wishes, and she has sent me. We look forward to having some of you back in so we can have some collaborations and we can learn from each other's experience. My leukemia patient, this is our stroke team that consists of Dr. Torres with the neuroradiologist as well as the neurologist looking at scans, making decisions. Some of the patients having a good time with play dogs. That's one of our transplant doctors. I think this is a sickle cell patient who was in the hospital for bone marrow transplant. This is one of our specialist, Dr. McCabe, with this patient. This is our neuroblastoma specialist, the Granger. This room is the MIBG suite, so these patients receive radiation as part of treatment for the neuroblastoma. And so the all the tape that you see on the walls is to prevent the radiation from escaping. There is a big, so many feet long iron wall. And when the patients are radioactively measured, the doctors and the nurses don't go inside the room because of exposure. So this is how the nurse check the patient. Those 3-4 are active. Make sure they're doing well. As you can see, all the bathroom, all the taps and everything covered up so that there's no exposure to rain. It can then escape immunity. LCH patient, we're going to talk a little bit about LCH. This is a little girl who was diagnosed in the newborn and came to us for the treatment. I was supposed to see her as an off-therapy follow-up visit, and this all showed with central diabetes and we had to treat him. Looking at peripheral smear in the lab, and this is our hospital night. Received a few awards for specialists, and so here's a organization. I hope some of you can in the near future, and we can go around.